Physiology of equilibrium. This is perhaps the most feared as well as neglected topic in E.N.T, but it is something that is asked in exams and it is something which is very important for the human body. So as people who are studying E.N.T, you should definitely know about it, and even if you are not in the world of E.N.T, you should try to understand the fascinating way in which the human body is able to maintain equilibrium. Now, let's see why it is so important for the human body to maintain equilibrium, what are the challenges it faces, and my aim in this video would be to ensure that the discussion is comprehensive so that students of E.N.T benefit from it, while also ensuring that the language remains simple enough so that everyone can understand it. So without further ado, let's get into it. So here we have a description of the functions of the vestibular system in mammals. It has basically four important functions. The first function is gaze stabilization. That is, you should be able to look at one object for as long as you want to look at it. Your body movement while you're walking, you should still be able to focus your gaze on that one object. Even if you're running, you should still be able to focus your gaze on that one object. Even if you're turning your head from side to side, you should still be able to focus your gaze on that one object. And this gaze stabilization is achieved through two important mechanisms. One is the vestibulo-ocular reflex, which is essentially a high frequency phenomenon, which is later on replaced by a low frequency phenomenon known as optokinetic nystagmus. We will discuss them in greater detail in later slides in this video. So that's the first function, gaze stabilization. Second function is ensuring that locomotion, that is traveling from one point to another, such as walking from one point to another or running from one point to another, is possible in a balanced manner. Also, your position, your current position, maybe you're sitting, maybe you're lying, maybe you're standing, that position also should be balanced. This balance in your body position as well as in your locomotion is ensured through the vestibulospinal reflex and the vestibulocholic reflex. Next, we are constantly experiencing gravitational forces on our body. So our body should be oriented with respect to gravity. As we have seen in videos of people on the moon or in the International Space Station, their body orientation is different from that of people like us on Earth. So our body has to orient itself with respect to gravity, and this is also achieved by the vestibular system. More specifically, the otolith organs, which we will discuss in greater detail in later slides. Next up, with every reorientation of the body, the autonomic functions of the body like heartbeat, breathing, all these things also need to be readjusted. You don't want a situation where your body has reoriented but the autonomic functions have not, because you want to not only reorient your body but also continue living. So these are the four most important functions of the vestibular system in mammals, and as I said, vestibular system is peripheral as well as central. So let's discuss the peripheral part first. Now, peripheral vestibular system is seen in our ear, and as we know, ear has three parts: the outer ear, middle ear and inner ear. Peripheral vestibular system is inside the inner ear. It is housed inside the temporal bone, which is in the skull, and the inner ear has two main functions. One is hearing, which we are not going to talk about here, and the other is maintaining balance or maintaining equilibrium, which is through the peripheral vestibular system. And even in the peripheral vestibular system, there are two parts: semicircular canals and the otolith organs. Semicircular canals are three in number in each ear: lateral or horizontal canal, superior or anterior canal, and posterior canal, which does not have any synonym. So lateral is also known as horizontal canal, superior is also known as anterior canal, and posterior is only known as posterior canal. These semicircular canals are responsible for perceiving angular acceleration, whereas the otolith organs, utricle and saccule, are responsible for perceiving linear acceleration. Utricle is predominantly in the horizontal plane, whereas saccule is predominantly in the vertical plane, although both utricle and saccule can perceive linear motion in both planes. Now, any motion of the human body can be described by 6 degrees of freedom, 3 rotational degrees of freedom and 3 translational degrees of freedom, which are mutually independent. They cannot be described by any other degree of freedom. So you need to know all 6 degrees of freedom, 3 rotational and 3 translational. So we'll start with the 3 rotational degrees of freedom, which are called yaw, pitch and roll. How do you remember this? Just imagine your face if you don't want to imagine the aeroplane. Yaw does not mean yes. So how do you say no? You move your head from side to side. How do you say, if somebody pitches you an idea, maybe a startup idea, like it is shown in Shark Tank, and you want to agree to it, so what will you do? You will nod. So pitch is nodding motion and roll is rolling on your side. So if you turn your head to the sides, that's rolling motion. And I have described this with the help of this aeroplane model, and I think you'll like it. So just once more, pitch, roll, yaw. Now we have the translational degrees of freedom. This is fairly easy. Left, right, up, down, fore, aft. Fore, aft of course means anterior, posterior, forward and backward. Let's move on now. And we will, at particular slide, we will pick one motion and we will analyze the role played by the lateral semicircular canal and the vestibulo-ocular reflex. Which plane have we picked? We have picked the yaw plane. Remember, yaw does not mean yes. So you are turning your head from side to side. It's largely a horizontal motion. So that's why the horizontal semicircular canal or the lateral semicircular canal has come into play. Now, in order to maintain gaze stabilization, vestibulo-ocular reflex is the most important. Let's do response. So let's look at it step by step. Now, at rest, hair cells, straight ahead perhaps, the discharging rate of the hair cells in both semicircular canals is about 90 spikes per second. The system, just like the cochlea, has hair cells. Okay, so hair cells seen in cochlea for hearing, hair cells seen in the vestibular system for maintaining equilibrium. These hair cells at rest in the semicircular canals has a resting discharge rate of 90 spikes per second. Now what are we doing? We are turning the head to the right. The moment the head is turned to the right, the endolymph inside both semicircular canals, that is the right semicircular canal and the left semicircular canals, this endolymph will not move as quickly as the head is moving to one side. So endolymph will lag behind due to inertia. This will result in the cupula bending to the left. Cupula is a part of the semicircular canal which is largely the terminal part where all the hair cells meet. So this cupula, because of its kynosia, is bending to the left. So now we have two semicircular canals. We have one semicircular canal on the right side where the head is turning. Since the head is turning to the right semicircular canal is the leading semicircular canal. In the leading semicircular canal, the stereocilia bends towards the kinocilium. The discharge increase the discharge rate. So of course, if you are leading, the discharge rate increases. Due to increase in the discharge rate, it causes depolarization of the hair cells. And the following semicircular canal, that is the left semicircular canal, the stereocilia is moving away from the kinocilium. Discharge rate is decreasing, resulting in hyperpolarization of the hair cells. So, because of this difference in discharge rate, you have the right side discharge rate increasing, the left side discharge rate decreasing. Because of this difference in discharge rate, movement to the right is interpreted by the vestibular nuclei. Vestibular nuclei are in the brain. There is the difference in discharge rate of the peripheral vestibular system. This difference in discharge rate is perceived as movement to the right by the vestibular nuclei in the brain. So as a result of this movement to the right, if you want to maintain the gaze at one point, your head is moving to the right, your eyes need to move to the left. And this movement of the eyes to the left is mediated through the vestibulo-ocular reflex by the vestibular nuclei by sending signals to the oculomotor nuclei. We need to understand two important words, ampulopetal and ampulofugal. Just like centripetal and centrifugal. If the movement is towards the vestibulum, it is called ampulopetal. If the movement is away from the vestibulum, it is called ampulofugal. The thing that you need to remember is ampulopetal is only excitatory in horizontal semicircular canal. In the other semicircular canals, ampulopetal is inhibitory. So ampulopetal movement is excitatory only in the horizontal or the lateral semicircular canal. In the superior and posterior semicircular canals, ampulopetal is inhibitory. We describe the motion of the head in the horizontal plane, where the two important semicircular canals that were stimulated are the right and left lateral semicircular canals. Why were the superior and posterior semicircular canals not stimulated? Let's understand this. Because the semicircular canals are positioned in our body in such a manner that they are antagonistic to each other, just like extraocular muscles. So as you can see in this picture here, this is the right posterior semicircular canal. They are parallel, right posterior semicircular canal and left anterior. Anterior is another name for superior semicircular canal. So these are parallel. So right posterior canal is antagonistic to left anterior canal, and this plane, this parallel plane is called, each side are RP plane, LARP plane, and this is right anterior canal, which again you see is parallel to the left posterior canal, which is the RALP plane, RALP. So LARP, LARP plane, and RALP, RALP plane. And the horizontal canals on the right side and the horizontal canal on the left side, they are also antagonistic to each other. That is why when there is horizontal movement, all three canals of each side are stimulated, but the posterior canal cancels out the superior canal on each side. So we are just left with the stimulation of the horizontal canals. The right side on movement to the right is the leading or the excitatory stimuli, and the left side is the following canal, so that's the inhibitory stimuli. I hope this explains it. If you have any questions, do ask me in the comment section. Now, because of these movements, there are some movements of the eyeball as well, which are largely rotational in nature. Okay. Now, these rotational movements of the eyeballs can be described by three terms. There is the vertical movement of the eyeballs, horizontal movement of the eyeballs, and the rotatory or torsional movements of the eyeballs. Now, the vertical movement of the eyeballs are mediated by the vertical semicircular canals, that is the superior and posterior, and saccule. The horizontal movements are mediated by the horizontal or lateral semicircular canal and the utricle, whereas the torsional movement of the eyeball is mediated by the vertical semicircular canals and utricle. So torsional is mediated by vertical semicircular canals and utricle. Even in torsional, the most important semicircular canal is the posterior semicircular canal. That is why you can remember the torsional nystagmus is seen in benign paroxysmal positional vertigo, where posterior semicircular canal is the usually implicated semicircular canal. Now let's understand which extraocular muscles produce these movements. There are 6 important extraocular muscles, 4 recti and 2 obliques. Medial rectus is causing adduction, then lateral rectus will cause abduction. Also, we can see that medial rectus is only active in the horizontal plane. But superior rectus and superior oblique are mostly antagonistic 2 out of 3, but they are both causing intorsion. Depending upon their rectus and inferior oblique, they are antagonistic in the first 2, but both are causing extorsion. This is an important point that you need to understand. These features of the extraocular muscles, then you will be able to understand which extraocular muscles contract due to stimuli from the semicircular canals and which extraocular muscles relax due to stimuli from the semicircular canals. And remember, ipsilateral as well as contralateral extraocular muscles act together. So if there is stimulus of contraction to the one muscle of the right eye, there will be stimulus to contraction of another muscle in the left eye as well. So let's understand how the extraocular muscles are stimulated by the different semicircular canals. Circular canal. So let's start with the lateral semicircular canal. Lateral semicircular canal, as we said, is only active in the horizontal plane, and the only muscles that are active only in the horizontal plane are the lateral rectus and the medial rectus. So, if the lateral semicircular canal is stimulated, then the same-sided medial rectus will get stimulated, and the opposite side lateral rectus will get stimulated for contraction. For relaxation, the same side lateral rectus and the opposite side medial rectus will be stimulated. So semicircular canal and the posterior semicircular canal. All we need to remember is superior semicircular canal is superior rectus of the same side. So superior semicircular canal is superior rectus of the same side. Along with that, we just mention the exact antagonist of that in the contraction column. Superior rectus of the same side, so inferior oblique of the opposite side. That is also contracted. Inferior semicircular canal antagonist will be inferior rectus, and the same side antagonist for the opposite side will be the superior oblique. Okay, so we have rectus above, oblique below, superior rectus of the same side above, and inferior oblique of the opposite side below. In the contraction column, in the relaxation column, we have the inferior rectus of the same side and superior oblique of the opposite side. In the posterior semicircular canal, we have to go for oblique above. So superior oblique above of the same side, and just the opposite of the same, on the opposite side we have the inferior rectus. Okay, and again in the relaxed column we have the same sided inferior oblique and the opposite side superior rectus. If you understand which comes first, you just remember the first muscle in each contracted column. The others you can figure out by just mentioning the antagonist nystagmus. Now let's look at unilateral vestibular deafferentiation and nystagmus. Now it's a big word. What does it mean? That the afferent supply or the afferent inputs, incoming signals to the vestibular system of one side has been completely shut. What kind of nystagmus will we see? What is nystagmus? Nystagmus are basically involuntary movements which are abnormal of the eyeballs. Nystagmus is never normal. These are abnormal, involuntary, that is automatic, not under your control, movements of the eyeball. Now nystagmus, as we have mentioned before, or the movements of the eyeball, as we have mentioned before, can be horizontal, vertical or torsional. Torsional nystagmus we mentioned that is seen in BPPV, where posterior semicircular canal is usually the canal that is implicated. But nystagmus itself is not just known in terms of its nature, that is whether it is horizontal, vertical or torsional. It is also known in terms of its direction, especially right beating and left beating. How do you understand if nystagmus is of the right beating type or the left beating type? You can understand it by two phases of nystagmus. So the eyeball can move towards the disease side. This usually is a slow phase, a slow movement of the eyeball to the disease side, and there is a rapid corrective motion to the normal side or the non-disease side. This rapid corrective movement is the fast phase of the nystagmus, and the slow phase is towards the disease. The direction of the nystagmus is given by the fast phase because this is more easily detected by the observer. So remember, direction of nystagmus is the fast phase, but it is opposite to the direction of disease. So let's look at this with an example. So suppose there is vestibular deafferentiation of the left side, then nystagmus will be right beating, and also it will be counterclockwise torsional nystagmus. The right vestibular deafferentiation will have left beating horizontal nystagmus, and in torsional nystagmus it will be clockwise. So as you can remember, if you are moving to the right, that is clockwise motion in torsional. If you are moving to the left, it is counterclockwise motion of the torsional nystagmus. So that part is easy to remember, but just remember that disease side is opposite to the direction of the horizontal nystagmus. So left vestibular deafferentiation, right beating horizontal nystagmus, right vestibular deafferentiation, left beating horizontal nystagmus. Let's move on. Now let's talk about the three important reflexes: vestibulo-ocular reflex, vestibulo-spinal reflex, and vestibulo-colic reflex. The effector organs for vestibulo-ocular reflex, as we have clearly talked about, are the extraocular muscles. So we need to know how many are there, what are the functions of the extraocular muscles, and which extraocular muscles are contracted by stimulation of which semicircular canal. If we know that, we can understand the kind of nystagmus we can see depending upon which part of the peripheral vestibular system is stimulated. So effector organs for vestibulo-ocular reflexes are extraocular muscles. Now the effector organs for the vestibulo-spinal reflex and the vestibulo-colic reflex are the extensor muscle groups seen in the neck, in the trunk, in the upper limbs, and also in the lower limbs. So these are the muscle groups which are mediating the orientation of the body in response to the changing inputs that we are getting from the peripheral vestibular system. So here an important principle is used, push-pull principle, which basically means the use of antagonistic muscles. So you need to the competing action of the extensor group with the flexor group in the trunk, in the torso of the body, whereas in the extraocular muscles we have the antagonist role played by the recti and the oblique muscles. So you need to remember the extensor muscle is the main effector organ, and it also has an antagonist which are the flexor muscles. So in the maintenance of equilibrium, whether it is in the trunk, in the neck, in the arms, or in the eyes, it's always the role played by both the agonist and the antagonist muscles, that is muscles that help in movement in one direction and the muscles that help in movement in the complete opposite direction. So we have discussed in detail the different aspects of the peripheral vestibular system, but these impulses, these signals get sent to the brain. This is known as central projections of the peripheral vestibular system, and largely there are areas in the brain which control balance. The most important is cerebellum, and we'll discuss that in greater detail now. So the first thing we need to remember is there is a cranial nerve which carries these impulses to the brain. Which cranial nerve is this? This is the 8th cranial nerve, which is known as vestibulocochlear nerve. It has largely three parts: superior vestibular nerve, inferior vestibular nerve, and cochlear nerve. Now cochlear nerve is only for hearing, whereas the superior and inferior vestibular nerve are responsible for the maintenance of equilibrium. Among these two, remember which parts of the peripheral vestibular system are supplied or innervated by the inferior vestibular nerve: posterior semicircular canal and majority of the saccule. If you remember that, the other parts of the peripheral vestibular system are supplied by the or innervated by the superior vestibular nerve, inferior vestibular nerve, posterior semicircular canal by inferior vestibular nerve, all the other parts by the superior vestibular nerve. Let's look at the path followed by the signals from the peripheral vestibular system to reach their respective destinations in the brain. So there is movement detected by the peripheral vestibular system. Movement of the body, it is detected by the peripheral vestibular system, that is the inner ear, semicircular canals, and the utricle and the saccule. These inputs then go through something called ganglion of Scarpa, and then they will reach something known as vestibular nuclei. These are in the brain. Now from these vestibular nuclei, other parts of the brain will get triggered, and then equilibrium will be maintained. This is the broad description of how equilibrium is maintained. Movement happens, detected by the peripheral vestibular system in the inner ear. The inputs will go through ganglion of Scarpa, reach the vestibular nuclei. Other brain centers will get triggered and equilibrium will get maintained. It's a complex procedure, but this is the most simplified description of it. Let's understand this in greater detail. So the first term we need to understand is what is the vestibular nuclear complex. This is something which is located at the pontomedullary junction of brainstem and cerebellum. That's the location of it. And this vestibular nuclear complex receives inputs from the peripheral vestibular system, and the maximum projections go to the nodulus and uvula. Nodulus and uvula are parts of the vestibular cerebellum. They receive the most number of projections. Now, classically, there are four vestibular nuclei in the brainstem. These are known as superior vestibular nucleus, lateral vestibular nucleus, medial vestibular nucleus, and descending vestibular nucleus. Important point to remember here is DVN is descending vestibular nucleus and not dorsal vestibular nucleus. So, superior, lateral, medial, and descending vestibular nucleus. These are the four classical vestibular nuclei in the brainstem. But there can be vestibular nuclei not in the brainstem, located in the periphery of the vestibular complex. These are known as Y group, interstitial nucleus of vestibular nerve, also known as E.N.T, parasolitary nucleus, also known as PSOL, and nucleus intercalatis. Now let's look at what is meant by ascending pathway and descending pathway. So inputs from the peripheral vestibular system, as I said, will go through the ganglion of Scarpa and will reach the vestibular nuclear complex. Which part of the vestibular nuclear complex? So they will enter at the level of the lateral vestibular nuclei and the rostral part of the descending vestibular nuclei. Once this level is crossed, then the inputs divide into an ascending pathway and a descending pathway. The ascending pathway will move upwards, so towards the superior vestibular nucleus and further on to reach the cerebellum. The descending pathway will innervate the central region of the vestibular nuclear complex. Ascending and descending division into ascending and descending pathway is happening at the level of lateral vestibular nucleus and rostral part of the descending vestibular nucleus. Next up, we need to understand which vestibular nuclei are stimulated by which part of the peripheral vestibular system. So, the semicircular canals stimulate all four vestibular nuclei in the brainstem, but primarily lateral vestibular MVN and SVN, medial vestibular nucleus and superior vestibular nucleus, are stimulated most by the semicircular canals, but the other two, lateral vestibular nucleus and descending vestibular nucleus, are also stimulated by the semicircular canals. Utricle stimulates lateral and dorsal part of medial vestibular nucleus and lateral and ventral part of superior vestibular nucleus. It also stimulates the rostral part of descending vestibular nucleus. Saccule, on the other hand, is stimulating descending vestibular nucleus, E.N.T, Y group, and also sends weak projections to other vestibular nuclei. Utricle, to remember here is utricle, because semicircular canal is sending to all four, MVN and SVN predominantly, but LVN and DVN also. But the difficult thing to remember is utricle. So remember that utricle is sending to 3 out of the 4. All 4 are getting from semicircular canals. The utricle is sending to 3 out of the 4. Which one has been left out? LVN has been left out. Utricle is not sending any inputs to the LVN. Utricle not to the LVN. Are not included. All by which letter is there in the name utricle of the starting letters of the 4 nuclei? L is there. M is also not seen in utricle. S is also not seen in utricle, and D is also not seen in the word utricle. So all these things which are not included, all these letters which are not included in the word utricle, they get inputs from the utricle. M, S and D. So MVN, SVN and DVN get inputs from the utricle. And if you want to remember it further, then you can remember that lateral and dorsal part of MVN, lateral and ventral part of SVN, and rostral part of DVN. But at least remember that utricle does not supply LVN. The other 3 vestibular nuclei get supply from the, or get inputs from the utricle. Now vestibular nuclear complex does not only receive inputs from the peripheral vestibular system, not just from the semicircular canals, utricle and saccule. It also receives inputs or afferents from the optokinetic system, which is of the eyes. That is the mechanism which takes over from the gaze fixation. We'll talk reflex to maintain gaze fixation. We'll talk about that later. It also gets inputs from the proprioceptive system, which is seen in the neck. This is again helpful in maintaining balance, and it also gets inputs from the cerebellum from the Purkinje cells. Now, from the vestibular nuclear complex is getting afferents, it is getting inputs. Vestibular nuclear complex also sends projections elsewhere. So there are second order vestibular neurons which project to different pathways. What are these different pathways? There is the vestibulo-ocular pathway, there is the vestibulo-cerebellar pathway, and the vestibulo-spinal pathway. So we will talk briefly about each of these pathways. This is what the vestibular nuclei does in order to maintain balance. It maintains balance through these three important pathways. So let's talk about the vestibulo-ocular pathway first. Now we have tried to make it as simple as possible. It is slightly more detailed, but we are describing it in a very simplified manner. So the afferents, where are the afferents of the vestibulo-ocular pathway coming from? They are coming from the SVN vestibular nuclei. We are not starting at the level of the peripheral vestibular system. So the afferents of the vestibulo-ocular pathway, they come from the central and dorsal regions of superior vestibular nuclei and medial vestibular nuclei, and the ventral part of the lateral vestibular nuclei, also the dorsal division of the Y group. So we have three vestibular nuclei, SVN, MVN, LVN, and the dorsal division of Y group. These are the sources of the afferents. Now these afferents will pass through medial longitudinal fascicle and the ascending tract of dieters to reach the oculomotor nuclei. And oculomotor nuclei controls the movements of the extraocular muscle, which produces gaze fixation through the vestibulo-ocular pathway. Next we have vestibulospinal pathway and DVN. LVN and DVN. The afferent part is not shown here, but tracts, the extensor muscles of the neck, trunk, and limbs. But the tracts are very important. You have the lateral and medial vestibulospinal tract, and you have the lateral and medial reticulospinal tract. Fairly easy to remember. Just remember which vestibular nuclei the afferents are coming from. In vestibulospinal, it is MVN, LVN, and DVN. In the vestibulocerebellar pathway, the afferents are coming from all parts of the vestibular nuclear complex, and the afferents are going to different parts of the cerebellum. What parts are they? Flocculus, paraflocculus, nodulus, and uvula. Now this flocculus, nodulus, these are parts of the vestibulocerebellum which are very important. So important that they can actually create an internal model of the orientation of the head. So even in a very dark room, you can still maintain your balance because there is an internal model of your head rotation in the vestibulocerebellum which helps in maintaining balance. So we maintain with the help of balance can be maintained with the help of even visual hints, visual inputs, just by looking at objects, even if your inner ear is not working. We will discuss that in slightly greater detail later in the video. But in a completely dark room where you can't see, you can still maintain balance with the help of the vestibulocerebellum because it has an internal model of the head orientation. So that explains to you how important the vestibulocerebellum is. By far it is the most important part of the brain and arguably the most important part of the body when it comes to maintaining balance. And of this structure, vestibulocerebellum, the important names are flocculus and nodulus. So you also have paraflocculus and uvula. There are other projections also from Additionally, there are other projections also from the vestibular nuclear complex. You just need to know the names. Details are not required. If you know the names, it's good. So names are on the slide. I'll just read it out. Nucleus prepositus hypoglossus. This is an important part of the brain which plays a role in velocity storage mechanism, which is details of Einsteinian physics, which we don't need to get into here. Then we have nucleus tractus solitarius, parabrachial nucleus, medullary autonomic centers for maintaining autonomic functions, which we talked about in the second slide, I believe, thalamus, and the parieto-insular vestibular cortex. Just knowing the names is enough. Discussing them in greater detail falls within the domain of neurologist, and I am just a humble otolaryngologist. As an otolaryngologist, all we need to remember is the most important part of the brain which plays the dominant role in fine-tuning vestibular functions is the vestibulocerebellum. And in the vestibulocerebellum also, flocculus and nodulus is the most important thing. Impulse test. Now let's talk about a test called head impulse test. This was described by Halmagyi and Carthois in 1988, so it's not that old. What is done here is the patient is asked to focus on a distant object. Maybe straight ahead or by turning their head to one side. They are asked to focus on one distant object. Now you turn the head either from side to center or from center to side. Suddenly. The turn has to be sudden. And the instruction to the patient has to be keep your eyes open and fixed on the side you are looking at. irrespective of how I turn your head. So in a healthy patient, if you turn the patient left, the gaze fixation will still be there. But if in a patient who has disease on one side, if you turn the patient's head to the healthy side, gaze will still be fixed. Patient will still be able to focus on that distant object. But when you turn their head to the disease side, say the side is right side has the disease. When you turn the head to the right, then the patient's eyes also move to the right. Okay? So if the patient has right-sided disease of balance, peripheral vestibular system, then if you move the head to the right, patient's eyes also move to the right. Patient is not able to keep their eyes fixed on the distant object. Now, how are the eyes fixed on a distant object in a normal person? That we need to understand. Before we go there, let's understand what is meant by refixation saccades. So, in a patient who has a disease of the right peripheral vestibular system, right inner ear, and you have turned their head to the right side, their gaze fixation is lost. Their eyes have moved to the right. But the body has realized that the eyes should not have moved. Now the eyes will be sent rapidly back to their normal location, that is towards the left, to fix their gaze at where it was supposed to be. This is a corrective mechanism, also known as refixation mechanism, and this rapid correction of the position of the eyeballs is known as saccades. Now let's talk about how the gaze fixation is maintained. How do you maintain your gaze at one object? Suppose you are running and you're looking at your phone, you're able to still look at your phone. Ideally you should not be due to health hazards, but in a moving car you can focus your gaze on a screen. Again, ideally you should not be doing it, but the point is that human physiology allows us to focus our gaze on an object even when we are moving, especially if we are running or we are walking, which is definitely movement, but we are easily able to focus our gaze. This becomes difficult in objects like a moving car or an aeroplane or a merry-go-round, because from an evolutionary point of view, this is a fairly recent phenomenon and our body has not adapted to these situations. That is why we experience something known as motion sickness. Some of us do. So we will discuss that also in a little bit of detail, and let's discuss how gaze is maintained or gaze holding is done, which is admittedly a complicated process. So let's simplify it. When there is head movement, say to the right, the eyes should move to the left to maintain the gaze. You are looking straight ahead. If you want to continue looking straight ahead, when your head turns to the right, then your eyes have to turn to the left. If this movement is sudden, then your eyes have to become stationary immediately when the head stops moving. So both movement to the opposite direction has to happen in conjunction with the head movement, as well as the movement has to stop the moment the head movement, that the nucleus prepositus control horizontal eye movements are the nucleus prepositus hypoglossus and the medial vestibular nucleus. And for vertical eye movement, the main parts in the brain that are playing the role are the interstitial cells of Kajal. So just remember these names. Interstitial cells of Kajal for vertical eye movements, for horizontal eye movements, nucleus prepositus hypoglossus and medial vestibular nucleus. Just the names are enough. Now, imagine a patient who has a bilateral labyrinthine deficit, which is just a fancy way of saying they have inner ear disease in both sides. Right side also, left side also, because there is an inner ear disease, the part of the inner ear which is responsible for maintaining balance. So this person has problem on both sides. It's not like the normal side can compensate for the other side. Which happens? Then the left peripheral vestibular system sometimes compensates for it. Sometimes the compensation also happens from the vestibular nuclei in the brain. But if there is a bilateral peripheral vestibular problem, that is bilateral labyrinthine deficit, how does this person walk in a balanced manner eventually? This is because of the role played by the visual cues and from the cues that we get from the proprioception as well. So visual cues, proprioception and vestibular inputs, they have a combined role. They interplay to maintain balanced locomotion, balanced body position. It's not just one system, it's the other systems also. But definitely, if somebody has a problem in the inner ear, then the others completely compensate for it to ensure that the motion is completely normal. There is very little redundancy built into the human physiology when it comes to maintaining balance. So each of these systems are important, but the other systems also can help in maintaining some sort of balance. So now we have understood how this person with bilateral labyrinthine deficit is walking in a straight line. He is relying a lot on his vision. So while this vision is maintaining his equilibrium, this vision is not able to play in understanding, active role in understanding words. So this person whose vision is helping him see things to maintain balance is not able to read street signs because that would be overburdening the visual system. This is a phenomenon that is seen in patients who have bilateral labyrinthine deficits who say they can walk on the street but they cannot read street signs while walking. Very interesting phenomenon, and just illustrates the beauty of human physiology, which is able to maintain equilibrium even in a condition where both sides inner ears are compromised but still are able to maintain balance, while clearly describing why one system, the visual system, is so much occupied in maintaining balance that it's not able to play its normal role of reading or helping in reading street signs. Next, let's imagine we are sitting in the audience of a famous Grand Slam, say Wimbledon, and we are watching two great tennis players battle it out. So, of course, if you have seen tennis on TV, you have seen spectators looking from the right side of the court to the left side of the court to follow the movement of the tennis ball. This tennis ball movement can be tracked by the human eyes by something known as the smooth pursuit system. In your own body by just placing your finger in front of your eye, little far away from the front, not immediately in front of your eye, you can't even see it, little far away, say half a meter from the front of your eye, and if you move that object from one side to another without crossing the edge of the eye, you don't want to cross the edge of the eye, then you can see that you can track the movement of your finger without that object becoming blurred. Even if you are moving your head from side to side, you can focus on the finger, and the image of the finger that is sent to your brain, it is not blurred when you're moving your head from side to side. However, on a merry-go-round, when the body is moving very fast, and merry-go-round of course is an object that we are not evolutionary adapted to, what happens is the immediate response is the vestibulo-ocular reflex, which is a high frequency response to maintain the gaze. But this fatigues over a certain point of time when it is taken over by the optokinetic system, which also then helps in maintaining the gaze. So gaze holding is primarily by vestibulo-ocular reflex for short duration, but beyond that it has to be taken over by the optokinetic system so that the gaze continues to be maintained even in a system as challenging as a merry-go-round. Now the last thing I want to tell you is, let's go back to the finger movement example. Place your finger in front of your eyes a little distance away so you can clearly see it, index finger, and now start moving it very rapidly. If you move your finger very rapidly, you will be seeing a blurred image of the finger. So despite trying to follow the movement of the finger, if you move your hand very rapidly, the image of the finger becomes blurred. Now do the opposite. Keep your finger fixed and try to move your head as rapidly as possible. You would notice that the image of the finger remains fairly stable. So optical image stabilization that we see in many phones, it's there in our body. And that's the beauty of the vestibular system, and I hope you enjoyed watching this video. If you have any questions, let me know in the comment section. I've tried to simplify what is perhaps the most difficult topic in E.N.T. Thank you for watching this video. Take care, bye bye, and as always, please don't forget to be awesome.